السلام عليكم ورحمة الله وبركاته وأسعد الله صباحكم وبسم الله نبدأ. Welcome to the first session of the 10th Saudi Society for Rheumatology conference, and I hope you will find it fruitful and beneficial as usual. It's my pleasure to introduce Professor Zahi Toma. He's the director, Toronto Lupus Program at UHN. He's Associate Professor of Medicine, University of Toronto, Scientist, Schrödinger Arthritis Institute, Krembil Research Institute. Okay, please, Doctor, it's a satellite, so we will see. Can you connect with Dr. Zahi, please? Is he ready?
The title of my presentation today is Treat to Target. So just allow me a second to share my slide with you. Okay, so we can start. This is my disclosure. And those are the objectives of my talk today. Taxonomy of lupus assessment, treat to target in lupus, and treat to target and its association with SLE outcomes. And I will start with the first objective, focusing on the taxonomy of lupus assessment. In 1992, the OMER Act, or the Outcome Measure in Rheumatology, proposed 5 domains to be assessed in randomized trials and observation studies. This includes disease activity, damage, health-related quality of life, generic and lupus-specific, adverse event, and economic costs. And as you know, in 2019, we have re-established the OMER Act SLE working group. And at this level, we have over 260 members who joined this group, representing 5 continents and 25 countries. And the purpose of this effort really is to update the SLE core outcome set. And if you're wondering, what do I mean by this? This means we need to generate or update the domain that needs to be assessed for lupus, particularly in clinical trials and observational studies. And when I say domains, this means disease activity, quality of life. And then once this is established, we will have a Delphi and a vote to agree on a set of domain that needs to move forward to clinical trial and observational studies. And for each of these domains, we need to identify the instrument. For instance, if we're talking about disease activity, we will be assessing the measurement property of SLEDAI, BILAG, Physician Global Assessment, and PGA, and other tools as well. And at the end, we will end up with the domain and their instrument. And this will finalize the work for the SLE core outcome set. And we're still at an early stage at this level. Now, I want to introduce as well today the concept of taxonomy of SLE assessment. And again, I'm referring to the assessment of the domains: disease activity, damage, quality of life, pain, and different aspects of patient-reported outcome. And you have to always think, how I'm going to measure this, and which tool, which instrument should I be using? And I would say here, for instance, if we're talking about disease activity, make sure at the end you use a tool that you have familiarity on how you apply it, how you interpret the score, and available for you in your clinic, or if you have an observational study. Regardless which tool you're going to choose, it's very important to set the goals or the endpoint and discuss this with your patient. And remember, depends on which measure you choose. It could be a physician-driven and patient-centered, patient-reported outcomes. And both are important, and they will give you a different aspect on disease assessment and management. So I'm going to move now to the second objective today, which is closer to the title of the presentation, Treat to Target in Lupus. First of all, what do we know about Treat to Target? What is the evidence around Treat to Target in medicine, and particularly in rheumatology? The concept of treat to target has been implemented in the management of chronic diseases for many years. And we know about treat to target in diabetes, in hypertension, and hyperlipidemia. But if you agree with me, majority of these diseases, they do have relatively an easy target in a way you can measure it in a standardized way, whether blood pressure or the level of the LDL or for HbA1c, for instance, for diabetes. And the choice of the target should be evidence-based, supported by task force recommendation, driven by data. And this data is the top of the pyramid for the evidence of the data is always randomized trial, followed by observational, case report, and others. Now, what do we know about the concept of treat to target in rheumatology? Does it exist? Yes, but we have to admit as well that treat to target in rheumatology is more complex. But there is no doubt that rheumatoid arthritis field has pioneered the development of treat to target. But as I said earlier, when we focus more on lupus, we know that it's a multi-organ involvement, which render our aim or job a little bit more difficult here to define or agree on what is the target and how many targets we're gonna have. And remember, when you say a target, probably if we're talking again to simplify things about disease activity or pain, you're trying to normalize the pain or improve the pain, right? And this could be, again, targeting different construct or parameters independently. But at the same time, you can put all these construct or parameter together in a combined or composite outcome. Think about the LLDAS, think about the SRI or the BICLA that we have seen in a number of randomized trials, which I will be talking particularly more about LLDAS and DORIS as treat to target in the next slides. Now back to the treat to target taxonomy. When you think about this concept, think about the construct that you need to measure and the conceptual framework that relate all these constructs that you're trying to measure to achieve an understanding of the treat to target. So first of all, you need to establish a target. You gotta take steps to achieve this target and monitor the target and adjust therapy to make sure we're always achieving the target. But you might wonder, when should I start thinking about the target? Probably from the minute you make a diagnosis of lupus. And we have to keep in mind as well, and this is very important, that it should be a shared decision between the patient and the medical team, because this will only improve the outcomes. Now, I showed you certain construct or items or parameters around the treat to target, but we all know that there is a lot of other parameters that we don't know about or we haven't defined, we haven't yet have a consensus around this. Not only this, think about the framework. How do they relate to each other? So all this needs to be established, and this will be done step by step. But if we want to simplify this, and again, this is based on a recent approach that was published in Nature Rheumatology last year. And as you can see here, the first thing you need to establish an individualized target for each patient. So consider the patient clinical status and patient medication as well. Then you're gonna take a step to achieve the target. And you need to monitor this target, as we said earlier, and you wanna optimize your strategy, therapeutic, to make sure you're taking into consideration the risk and benefit associated with the therapy plan. Now, EULAR has proposed an overarching principles in 2014, and I'm gonna review with you these principles. The first one being the management of lupus should be based on shared decision between patient and physicians and the medical team. The second principle is that treatment of lupus should aim at ensuring long-term survival, preventing organ damage, optimizing health-related quality of life, pain, fatigue, anxiety, depression, sleep, and others, by controlling disease activity and minimizing comorbidities and drug toxicity. The third principle, the management of lupus, requires an understanding of its many aspects and manifestations, which may have to be targeted in a multidisciplinary manner. And the fourth principle is that patients with lupus need regular long-term monitoring and review and/or adjustment of therapy. And really, if you think about this, you're already doing this in your clinical trial, but we're just consolidating this in principle here at this level. So again, this paper in 2014 not only described for principle, proposed for principle, but also they provided a list of 11 recommendations. And I'm gonna go over it here relatively quickly. The first recommendation being that we should always aim to achieve remission when we treat patients with lupus. And if you can't achieve the remission, you have to achieve the lowest possible disease activity, partial improvement, whether 25 or 50%. And we did see recently the KDIGO recommendation for the management of lupus nephritis, where ideally would like to see a 25% decrease in the level of proteinuria by 3 months and 50% by 6 months. Again, you can be a little bit more flexible when you have someone with nephrotic range of proteinuria or large amount of proteinuria, but at least there are targets there to guide us on how to adjust and make change in the therapy. The second recommendation is prevention of flare. The third being that patients who are clinically asymptomatic, there is no need to change and particularly escalate the therapy simply if they only have persistently active serology. Always think about clinical and laboratory and serological activity. And again, here, when we talk about serological activities, we're referring to the biomarkers that we have at this level or serological blood tests that reflect disease activity. And this is particularly anti-dsDNA antibodies and C3 and C4 levels. We need to aim to prevent damage, and we need to put into the equation different aspects of health-related quality of life, including fatigue, pain, depression, anxiety, and others. So the same way you try to control disease activity and damage, we need also to make sure that we talk to the patient, or you collect different instruments, or give the patient a patient-reported outcome measure to reflect on these concepts and make sure that you're also achieving improvement in these concepts. The sixth recommendation being early recognition and treatment of renal involvement, eventually in lupus nephritis, is strongly recommended. I would say actually not just only renal involvement. We should recognize all features, regardless which organism is involved. And we know certain organs are more difficult to diagnose at this level, particularly when we talk about CNS lupus. For lupus nephritis, following induction therapy, at least 3 years of immunosuppressive maintenance should be continued. And I would say in some patients, we know already that it should be even beyond 3 years. We have to always aim, whenever possible, to lower the dose of steroids. And if you can, we would like to completely stop prednisone. We have learned that any dose of prednisone is associated with damage, even 5 milligrams and lower. So it's always better to be off prednisone if we can. Management of antiphospholipid syndrome in the context of lupus. Anti-malarial treatment are very important in the management of lupus patient, standard of care therapy. And we have to as well consider different immunomodulation, immunotherapy as well in the management of lupus. Now let's sit back and think again about the goals. Whether you are in you have a cohort study, observational clinical trial, or your clinical practice, real practice, I mean. So it's always very important to share with the patient the goal and the time to achieve partial or complete recovery. And you know that this change based on the organ involved, it's different for proteinuria compared to arthritis and skin rash. And we gotta always share with the patient not only the goals and the time we have to talk about the potential adverse event from the medication. But let's bring it more to a explicit example for today's presentation. Treat to target, I'm gonna focus more about disease activity because we already at this level have a realistic target. Remission of disease activity with the utilization of different tools such as DORIS or LLDAS, or probably other, depends again what you're using in your clinic. But if we want to talk about the LLDAS, so LLDAS, which was introduced in 2016 by the Asia Pacific Lupus Collaboration. And again, it stands for Lupus Low Disease Activity State. So it includes different components. The first being SLEDAI. And again, SLEDAI stands for SLE, Disease Activity Index 2000, and has to be at least 4 or less, with no activity in major organ system. This means renal, CNS, cardiopulmonary, vasculitis, and fever. You cannot have new feature of lupus disease activity compared to previous assessment. And your PGA should be 1 or less. You gotta have as well a dose of prednisone 7.5 milligrams a day or less, and you need to have a stable immunosuppressive therapy compared to the previous assessment. So this is the LLDAS. The next tool is the DORIS, which is a definition of remission. And DORIS is more stringent than LLDAS. You can see here it's a clinical SLEDAI equal to 0. So remember, SLEDAI has 2 components. Serological, particularly dsDNA antibodies, which gives you a weight score of 2, and C3 or C4, which gives you as well a weight score of 2. So the focus here is clinical. So if you have the dsDNA and complement present or low, that's okay. And the physician global assessment should be less than 1 compared to the LLDAS. It's at this level less than 0.5. So again, more stringent and less prednisone compared to the LLDAS. So this time is less than 5 milligrams and stable immunosuppressive and biologics. Now here you can see head-to-head the LLDAS and the DORIS. And as I highlighted earlier, the DORIS is more stringent, lower SLEDAI, lower PGA, lower prednisone. Now you might say, but we don't like prednisone, and both definitions allows prednisone. But at this level, we have probably to accept this as a definition, but there is no doubt we need to work on developing definition without prednisone, and hopefully we will be able to achieve this target with the availability or implementation, the use of new biologic therapy for lupus patient. So now I'm going to move to my third objective, which is treat to target and association with SLE outcomes. So I showed you earlier the LLDAS and DORIS for disease activity. So let's think about some outcomes. We would like to see if there is an implication on decreasing damage accrual, decreasing flare, healthcare utilization costs, and decreasing as well hospital admission, improving mortality by decreasing it, and increasing or improving health-related quality of life measure, fatigue, anxiety, and so on. And at this level, there are a number of studies, and this is based particularly on observational studies, but some of it as well already is based also on post hoc analysis of randomized trial. And you can see this is check mark for all for both definition for all these items. So there is no doubt at this level we have enough evidence to show that the LLDAS and DORIS really are good treat to target for the management of patient with lupus. So this is another example here based on the data from the Hopkins cohort, which included almost 1,400 patients followed from 1987 to 2016. And you can see here that 50% of the patient did achieve this outcome, the LLDAS. And what you're seeing this in this busy table is the amount of time spent in the state of LLDAS. So there is no doubt, which is highlighted here in red, patient who stayed more time, 50% to 70% of the time, or even greater than 70%, they do have less damage accrual over time. And this is reflected by the improvement in the hazard ratio, which is less than 1. And again, you can see the drop in the relative risk here with the longer time spent in the state of LLDAS. Now, the question, would this be applicable also for DORIS? So this is also analysis based on the Hopkins cohort. And what you can see here as well, that the clinical remission on treatment, which means the way the DORIS definition is described, was achieved by 27% of the patient. But they also challenged the definition here, and they said clinical remission with no treatment, which means no prednisone and no immunosuppressant. And that's ideal situation, particularly when we say no prednisone. And you can see that the number is lower, but still some patients were able to achieve this outcome. So, but we can see clearly here that the LLDAS is an easier target to achieve compared to DORIS based on the percentage, the prevalence, and still LLDAS also is associated with less damage. But when we look at the analysis here, we can see that the clinical remission on treatment was also associated with damage. So this is great. Both definitions, actually, whether you say the DORIS or LLDAS, we know already that they predict less damage over time. And again, even a small percentage of time in clinical remission on treatment was indeed associated with reduced damage. So what are the take-home messages? So treat to target is possible in lupus. It's a clinical reality at this level. But the fact is that there is no international consensus on different treat to target concept at this level. But if we talk about disease activity, I showed you the data for DORIS and LLDAS. And there is no doubt the new therapy will enhance our ability to achieve these targets moving forward. So the treat to target is associated with favorable outcomes. I showed you the data from the Hopkins cohort, but there is similar positive data from the Gladel, from the Padua, the Chinese, Amsterdam, and really other cohorts as well, and some RCTs trials as well. So treat to target is challenging to define in lupus, but possible. And treat to target is an evolving and dynamic concept because I showed you that you can even eliminate the prednisone if you want and the immunosuppressant from the DORIS definition. And we're going to be able to do more once we have better therapy and work on different targets that I showed you earlier, not just only disease activity. So I would like to acknowledge all the team at the lupus clinic. This is in Toronto. And I want to take this opportunity to invite all of you to the Lupus 16th International Congress, which will be in Toronto. Save the date. Looking forward to welcome all of you in Toronto. I wish you the best for the rest of the meeting today and tomorrow and after tomorrow. And unfortunately, I'm not going to be able to stay with you for the question and the answer sessions because that will be very late for the time in Toronto. Thank you and have a great meeting.
Thank you, Dr. Zahi.